Hello, my name is Gerald Lerman. I'm Clinical Professor of Anesthesiology at the John R. Oshai Children's Hospital here in Buffalo. This lecture is entitled Pharmacology, Developmental Pharmacokinetics and Inhaled Agents Part 1. And we will review the pharmacology of inhaled agents as they relate to pediatric anesthesia. We'll begin with a question. The question is, inhaled agents may worsen some clinical conditions in children. Of the following, which is least likely to be true in children? A. Nitrous oxide reduces the MAC of all inhaled anesthetics similarly in children. B. Desflurane increases airway resistance. C. Sevoflurane is least likely to produce carbon monoxide in desiccated soda lime. And D. Right to left shunts exert their greatest influence on the wash-in of less soluble agents. Which is least likely to be true? I'll give you a moment to review these. And the answer is, nitrous oxide does not reduce the MAC of all inhaled anesthetics similarly, as we will discuss in the next few moments. The two commonly used inhaled agents in children currently are desflurane and sevoflurane. Halothane, shown at the bottom, is no longer used in most countries, at least certainly in North America. Desflurane and sevoflurane are both ether anesthetics, but they differ in that desflurane is a methyl ethyl ether and sevoflurane is the only methyl isopropyl ether that is currently used. This different conformational structure of sevoflurane brings into focus several different properties compared to the methyl ethyl ethers, desflurane, and the older ones, isoflurane and enflurane. And we'll spend a fair bit of time differentiating the metabolism of these two groups of ether anesthetics. But let's begin with the basic wash-in of inhaled agents in children. And we can see on this classic slide from Salonitrin-Rakow that compared to the wash-in of halothane in adults, the wash-in of halothane in young children was about 50% more rapid. This was an interesting observation in that it helped to explain why it is that children appeared to suffer much greater cardiovascular and respiratory depression early on in exposure to anesthesia like halothane than did adults. Now, how can we explain this more rapid wash-in that Salonitrin-Rakow first described? Well, we attribute them to four specific differences. In neonates and young children, they have a much greater alveolar ventilation to FRC ratio, primarily because of their increased oxygen demand. So hence ventilation must be greater in these young kids. That draws in much more anesthetic per unit time. In fact, the ratio of alveolar ventilation to FRC is about 5:1 in neonates compared to only 1.5:1 in adults. Secondly, an increased cardiac output. And one might expect that an increased cardiac output should actually slow the wash-in of inhaled agents. But the increased cardiac output in neonates is crucial because 18% of the cardiac output in neonates perfuses the vessel-rich group, or as in the adult, only 6% of the cardiac output reaches a vessel-rich group. What the outcome of that is that the time to partial pressure equilibration of inhaled agents in the vessel-rich group is much faster in the neonate and infant, and hence the uptake during that early phase of anesthesia is completed in the vessel-rich group, and the blood returning to the lungs will come back with the same amount of anesthetic, as it left with, because there's less uptake. The uptake at the vessel-rich group is no longer an issue. So increased cardiac output speeds the rate of equilibration of anesthetic partial pressures in the vessel-rich group in neonates. And the third and fourth reasons that we see a more rapid wash-in of inhaled agents in neonates compared to adults are the decreases in solubility in the neonates, both in blood and in tissues. In terms of the blood and the blood gas partition coefficient, we published several years ago that the blood gas partition coefficient in the newborn period, shown here on the far left, are much lower than that in adults and the elderly for all these anesthetics, from the less soluble isoflurane and enflurane to the very soluble halothane and methoxyflurane. Similarly, the anesthetic solubilities in brain tissue are much less in neonates than they are in adults. This means that the neonate has a smaller capacity to take up inhaled agent before it reaches a partial pressure equilibrium with that in the blood. And therefore, the effect on the organ system, in this case the brain, and the uptake are different in the neonate than in the adult. And how can we look at a clinical relevance of these differing solubilities? Well, we can look at the tau, or time constant, for the brain in terms of the volume of the brain times the solubility of the anesthetic in the brain divided by the brain blood flow. And we know that for every 100 mils of brain tissue, there's about 50 mils per minute of blood flow. And those are pretty constant and normalized, constant numbers for all ages. But the difference that may affect the time constant is the blood solubility, brain solubility. And in this case, when the brain blood solubility is 2, the time constant for the brain is 4 minutes, which means that about 95% equilibration, which occurs after 4 time constants, is about 16 minutes. However, if the brain solubility of the inhaled agent were only 1, that would mean that the time to partial pressure equilibration is about 8 minutes, half of that with a more soluble agent. So what this tells us is that it's one thing to wash in the anesthetic to the lungs. It's another thing to anticipate how long will it take for the brain to reach partial pressure equilibration, which after all is what we're aiming for, to put the patient asleep, because of the time constant for the anesthetic to reach partial pressure equilibration in the brain. And with young babies, neonates, and infants whose solubilities are less than in adults, the time constant is much less, and therefore one can anticipate earlier responses. Now, many of us talk about safety factors in terms of administering inhalational agents, and one might ask the simple question, which is a safer role in which to give inhalational agents? A role in which the patient is breathing spontaneously, or a role in which the patient's lungs are ventilated and controlled ventilation? And in this slide here of halothane administration to dogs, we see on the left the dogs were breathing spontaneously, and increasing inspired concentrations of halothane from 0.3 to 4% were administered. And the wash-in of the anesthetic was measured on the left or y-axis, and you can see that it didn't really matter what the inspired concentration of halothane was, but all of the curves merged at about 0.6 or 0.65 FA over FI, which is alveolar to inspired ratio. And as we gave higher and higher concentrations, the wash-in was no faster or no slower. In other words, the more anesthetic we gave, the slower the breathing, the less uptake there was. The lower the anesthetic-inspired concentration, the more rapidly the dog breathed. And in the end, the wash-in curves are almost overlapping and identical. This represents the negative feedback effect of spontaneous respiration during inhalational anesthesia. And it's a protective mechanism whereby decreasing respiration prevents an anesthetic overdose from exposure to high concentrations of inhaled agents. Now let's just contrast that to the figure on the right, where we see controlled ventilation being administered to the dogs at low concentrations, up to 1.5% halothane. And we see the wash-in curve that's somewhat similar to the curves on the left side of the slide. And all of the dogs survived the 1 hour of exposure to anesthesia. However, when higher concentrations of halothane were administered, specifically 4 and 6%, under controlled ventilation, at 4%, about a third of the dogs died, and 6%, all of the dogs died by 20 minutes. And the reason this occurred is that at these high concentrations, we bypassed the negative feedback effect of respiratory depression, and we now have only cardiovascular depression. And the lower the cardiac output when facing higher concentrations of halothane, the higher the partial pressure of anesthetic builds up in the lungs because less blood is circulating, and therefore the partial pressure rises higher in the brain and other tissues until eventually the animal succumbed. So controlled ventilation at high partial pressures can be a lethal circumstance and is a dangerous concern with agents that can depress the myocardium. Halothane was terrible, very potent myocardial depressant. The more recent ether anesthetics seem to be less myocardial depressant and more forgiving. And so we don't see quite as a dramatic effect with sevoflurane and desflurane. We will probably see a much milder effect and more forgiving amount of cardiovascular depression. So the respiratory depression is a negative feedback loop, as it says on this slide, and it stops ventilation at high concentrations. Whereas the controlled ventilation bypasses this loop and allows an anesthetic overdose. And we can see how this is featured with ventilation. We can see here as the ventilation increases with a soluble anesthetic, we have a much higher FA over FI than lower partial pressures. Whereas with an insoluble anesthetic, ventilation almost doesn't make a difference because the FA over FI is already up at 90%. It can't increase that much more by ventilating the lungs more aggressively. So ventilation and the ability to drive anesthetics into the lung and create a more dangerous situation, unpredictable in terms of outcomes, myocardial depression, is much greater with the more soluble anesthetics. With ether, methoxyflurane, and halothane, they're no longer on the market in North America, and we're dealing with the less soluble agents like desflurane, sevoflurane, isoflurane, which are less affected by increases in ventilation. And we've already mentioned the cardiovascular depression that will occur with the positive feedback loop of controlled ventilation, and that ultimately may cause a patient to succumb. And here we can see that on the wash-in curves, stylized wash-in curves from Eager, where we see with a less soluble agent like nitrous oxide changing the cardiac output from 18 to 2 liters a minute really didn't speed the wash-in of nitrous so that it would be any more dangerous at low cardiac output than high. But if you look at the more soluble agents, we have almost a threefold greater increase in the FA over FI in a low cardiac output state, shown here in the pink arrows. So a patient who's in heart failure or whose myocardium is not functioning very well at all is much more sensitive to the more soluble agents and the myocardial depression that may ensue. Now we can also talk about the effect of shunts in a right-to-left shunt and whether or not soluble or insoluble agents are more sensitive. So while ventilation and cardiac output are particularly effective on soluble agents, with the right-to-left shunts, the effect is more dramatic with insoluble agents. You can see the difference between the end tidal and the arterial or blood partial pressure of anesthetics with a very soluble agent, almost no difference in the PA over PI or FA over FI, either way, alveolar to inspired fraction or partial pressure with a soluble anesthetic. Whereas when you contrast that with a very insoluble agent like cyclopropane, we have almost 100% increase in the FA over FI with a right-to-left shunt. Now, how does that make any sense? Well, I'll explain it in the stylized graph here. On the left, far left under A, we see no shunt, which is a tracheal tube in the endotracheal tube in the trachea, and two stylized lungs, or represented by these alveoli. And here ventilation occurs equally into both alveoli. We have one ventilation unit, and that brings us 1 unit in the pulmonary venous drainage from each lung, and the combined average is 1. And so that's a normal situation. Now let's look at this model of right-to-left shunts and see what the effect would be on a soluble and an insoluble agent. So in the middle part, under B, we can see a right-to-left shunt, which I have created by placing the endotracheal tube in the right mainstem bronchus, and given the ventilation that was to each lung of 1 unit, now combining it to the right 1 lung. And you can see an alveolar ventilation level of 2, none on the other side, because there's no ventilation. Now, because soluble agents are dramatically affected by ventilation, we actually are able to achieve a much higher venous partial pressure by doubling the ventilation to this lung, and it's at 2 compared to 1 with the tube in the trachea. And on the other side, it's 0. And if we assume that there's equal blood flow to the 2 lungs, the average is 1. Once again, indistinguishable from the original position of the endotracheal tube. But what happens if we used an insoluble agent with that tube in the bronchus? We double the ventilation to that lung, no question about it. But because ventilation has a minimal effect on the washing of an inhaled agent that's insoluble, we don't really achieve any more in that pulmonary venous drainage than when we had the tube originally in the trachea. And the other side has no ventilation, which means the venous content is 0. And when we combine those 2 drainages, we only end up with a value of 0.5. So this is a model to illustrate to you how important it is, whatever the shunt, whether it's intrapulmonary from an endobronchial intubation or pneumonia, or intracardiac from a tetralogy of Fallot with a right-to-left shunt, that insoluble agents have great difficulty achieving the expected partial pressure in the bloodstream because it cannot make up for the shunting by doubling ventilation or tripling ventilation. And here we can see it once again, that the ventilation of the insoluble agent is minimally affected, increasing 4-fold from 2 to 8 liters a minute. Whereas with the very soluble agent, the FA over FI, the wash-in, is much greater, almost 3-fold, with increasing the ventilation fourfold. So ventilation, cardiac output affect primarily soluble agents, but shunting is affected primarily, affects primarily insoluble agents, and we cannot compensate for that. And so what do? Well, we always maintain a maximum concentration of sevoflurane, usually 8%, in, for example, premature babies or neonates who need a bronchoscopy and have chronic lung disease. We have to administer enough oxygen, but we try to refrain from decreasing the inspired concentration of sevoflurane because the patients are probably not very deep with a large right-to-left shunt. Most importantly is to recognize that we probably need supplemental IV drugs to keep these babies asleep during an inhalational agent, during a surgical procedure. Now, the washout of the inhaled agents follows a predictable pattern, and that is just as sevoflurane and desflurane are insoluble during the wash-in, they're also rapidly eliminated due to their insolubility on the outside, on the other end, whereas halothane and isoflurane are washed out more slowly, and hence recovery is slower after those agents. And we exploit those in many of our outpatient surgical procedures these days. Our next question we want to pose is, when deciding which anesthetic is most appropriate for a child, a clear understanding of the pharmacology of the agent is essential. Please identify the most correct statement about these anesthetics. Emergence delirium occurs after propofol. B, sevoflurane has the longest half-life in the troposphere. C, inorganic fluoride toxicity after inhaled agents depends on their affinity for cytochrome P452E1. And lastly, desflurane is a methyl isopropyl ether anesthetic. The most correct statement here is that inorganic fluoride toxicity is related to the 2E1 isoform. Now let's talk about the effect of MAC and metabolism of inhaled agents. The relationship for MAC and age is complex and nonlinear. We don't completely understand the mechanisms for the effect of age on MAC, and we don't understand why the relationships actually are different for different anesthetics. In the case of sevoflurane, the MAC is most peculiar in comparison to the other ether anesthetics and halothane, in that over the range of childhood, from about 3 years up to about 10 or 12 years, the MAC is constant at 2.4%. And then, for those infants under 6 months of age, the MAC is about 3.2 or 3.3. Why is the MAC of sevoflurane constant over most children's ages? And why is it a stepwise increase in young infants? It has evaded explanation, and we really aren't any closer now than we were when we published these data 20 years ago. And they are very different, by the way, as we'll see in a moment, for the effects of age on halothane, isoflurane, and desflurane. In terms of the effect of sevoflurane at 1 MAC on heart rate and blood pressure, we can see that heart rate has hardly changed with sevoflurane at 1 MAC before and after skin incision. So in contrast to halothane, sevoflurane does not particularly decrease the heart rate, at least at 1 MAC. It does decrease the blood pressure, systolic blood pressure, in neonates and young infants about 25 to 30% before skin incision. But in older infants and children, its effect on blood pressure is somewhat attenuated at 1 MAC. And here we display the MAC of isoflurane with age, and the same kind of graph, appearance of the shape and form for halothane has been reported, and somewhat similar to desflurane, with the MAC decreasing from adults throughout childhood and peaking for isoflurane, halothane at about 1 to 6 months of age. In the case of desflurane, it's 6 to 12 months of age, and then decreasing in younger babies, with neonates, premature infants down to less than 32 weeks having the least MAC. So these data were most interesting because we demonstrated that actually we can measure the end-tidal concentration of isoflurane in premature babies whose response to skin excision could be attenuated in 50% of the cases. And it was not zero. It was in the range of 1.3, 1.4% isoflurane. And this was one of the first studies in 1987 demonstrating the need for anesthesia in these young infants. Now, does the MAC change in cognitively impaired children? And it does. At least data with halothane. Franz Frey noted that the MAC of halothane in children with cognitive dysfunction was about 20% less than in normal healthy children. And that particularly in those without taking anticonvulsants. And those children who were taking anticonvulsants, it was another 15% less. So MAC is inhibited in children who are cognitively impaired. But the additivity of MAC of inhaled agents with nitrous oxide is not uniform throughout all agents. And you can see here that in the case of halothane, if we administer 60% nitrous oxide, we reduce the MAC about 65% compared to 100% oxygen. In the case of desflurane and sevoflurane, adding 60% nitrous, however, has an attenuated effect. The MAC is only reduced 26 or 20% with these two agents. And why does that happen? It's not clear. But these are the only two agents, sevoflurane and desflurane, for which the additivity of nitrous oxide to the MAC of agents does not hold true in young children. In adults, the additivity of nitrous oxide and these two agents remains a simple summation. Also interesting are data that showed in patients who were homozygote for red hair that their MAC is about 15 to 20% greater than in children and in adults who are brunettes and aren't homozygote for red hair. So that suggests that we need to increase the MAC in these patients. Now let's spend a few minutes talking about the metabolism of inhaled agents. The anesthetics that are metabolized to the greatest extent are methoxyflurane and halothane, 50 and 20% each. But the newer agents are metabolized to a much lesser extent, with halothane leading the pack at about 5%, enflurane, which is no longer available, and then isoflurane 0.2% and desflurane 0.02%. So the products of in vivo metabolism certainly are much reduced with these new inhalational agents. So when sevoflurane was first introduced, the question and concerns arose regarding fluoride nephrotoxicity because methoxyflurane, the prototypical inhaled agent that caused high output renal failure, had been attributed to high concentrations of inorganic fluoride released with this agent. The interesting thing is methoxyflurane never caused high output renal failure in children. And the four possible reasons for the sparing of nephrotoxicity with high concentrations of inorganic fluoride in children may have been due to decreased metabolism of methoxyflurane in children, or the increased removal of inorganic fluoride, uptake of inorganic fluoride in bone, or the increased organic elimination of inorganic fluoride. In any case, methoxyflurane was removed from clinical availability because of adult-induced high-output renal failure, attributable to high concentrations of inorganic fluoride in the bloodstream. But it's interesting that in the toxicology literature, high concentrations of inorganic fluoride do not cause kidney disease. In fact, they're primarily responsible for heart failure. So why is it under anesthesia we saw this relationship? And the reason is that we didn't really understand that the ability of methoxyflurane to cause kidney damage was not dependent on the blood concentration of inorganic fluoride, but it was dependent on the local concentration of inorganic fluoride in the kidneys, because the kidneys contain cytochrome P452E1. And it is in the kidneys where this enzyme breaks down methoxyflurane, releases inorganic fluoride locally, and poisons the tubules, leading to high output renal failure. Not so much the case with sevoflurane. And you can see shown here, both in the liver and in the kidney, the affinity of 2E1 for sevoflurane is dramatically reduced compared to methoxyflurane. And therefore, the local production of inorganic fluoride is much less after sevoflurane anesthesia and has never been shown to cause nephrotoxicity. Compound A is another potentially toxic compound that's released by inhalational agents, specifically sevoflurane at low fresh gas flow, and in presence of a carbon dioxide absorbent, it produces 5 compounds. The most common is an olefin known as compound A. And in rats, compound A will produce renal failure or renal damage. But there has been no evidence of compound A toxicity in either primates or humans to date. The ability of CO2 absorbents to break down sevoflurane and cause compound A production depends on the type of absorbent that's present, and that is in the presence of only calcium-based salts in the CO2 absorbent, removing the sodium and the potassium salts, as in the case of Amsorb, compound A is not even produced. And so we can eliminate the fear and concerns about compound A by simply switching to the type of absorbent like Amsorb. And here we can see the amount of compound A that's produced over time with general absorbents and Amsorb. There's absolutely no compound A produced by Amsorb, which have only calcium salts. In children, the amount of compound A increases as the body surface area increases. But once again, compound A has not led to any kidney damage in young children. Carbon monoxide toxicity is another feared complication of inhaled agents interacting with CO2 absorbents. This case, in the presence of desflurane, isoflurane, and enflurane, when it interacts with desiccated soda lime. How does the soda lime become desiccated? Because the fresh gas flow is left on over, for example, a weekend, and the reservoir bag is removed from the circuit, and therefore gas flows backward through the absorbent and dries it out. We cannot measure carbon monoxide levels, and we can reach lethal concentrations of carbon monoxide after a period of time, occurring, for example, on a Monday morning when the machine was left on, fresh gas flow was flowing, and you suddenly exposed the patient to desflurane or isoflurane. Once again, removal of the sodium and potassium salts in the absorbent, such as in the case of Amsorb, completely eliminates the risk of carbon monoxide toxicity, as we see here. Normal sodium absorbent, normal soda lime absorbent, and Amsorb. Absolutely no carbon monoxide produced. So these are all manageable and preventable problems. So we've had a quick review of the pharmacology of inhaled agents in children, understanding some of the effects such as shunting, and then spoken for a brief period reviewing at least the key issues of metabolism as they relate to the inhaled agents both in vivo and in vitro. Thank you very much.